Welcome everyone to the webinar Dental Implant Restoration Registry Study Updates. This webinar is sponsored by the National Dental Practice-Based Research Network, and we will be talking today about the DIRR study. We have here today with us Dr. Nico Geurs. Nico is the PI of the Dental Implant Restoration Registry. He is a periodontist, clinical researcher, professor, and chair of the periodontology department at the University of Alabama at Birmingham. He is also our interim dean of the UAB School of Dentistry. He's interested in doing periodontal research. His focus are on periodontal health, dental implantology, periodontitis, bone grafting, regeneration, and systemic health. Joining Dr. Geurs today is Dr. Andrew Shuler. Dr. Shuler owns a general dental practice in Clinton, Wisconsin. Dr. Shuler earned his DDS degree at the University of Minnesota. I love that Dr. Shuler stays well-informed in dental advance by regularly taking continuing education course like this one today and participating in practice-based research. He has been a member of the network since 2017, participating in many studies. Dr. Shuler is joining us today to talk about his experience doing the DIRR study. But first, let's talk with Dr. Geurs. Dr. Geurs, please give us an update about this study.
Well, thank you, Joanna, for the opportunity to speak to our main cohorts within the study, and those are the practitioners that are really building our registry. So I want to remind everybody of our study goals. So we're building an implant registry to document implant therapy as it's performed in practice. And we find that very important because we want to really understand what happens in implant dentistry in a regular practice setting. Most of our information that we have comes from studies that are done in atypical environments at universities with well-controlled scenarios and protocols, but this doesn't always translate directly to practice. So during our design of the study, we developed these goals, and our goals are to quantify the incidence of biologic and prosthetic complications, mostly so to where we can then assess risk factors for these complications. And ultimately, we want to reach a consensus on how we should move forward to prevent these adverse outcomes. So our study has been ongoing, and we want to report on the success. We're right now in Q1 of 2024, and we have accomplished quite a lot. So we have been able to enroll a cohort of practitioners from all of our regions. And all these areas have contributed practitioners that are ready to enroll our patients. So this is the next important cohort. Practitioners are critical for us to get the patients, and we've enrolled a significant number of patients. Look at the practitioner enrollment. We can kind of see that it took a while for us to get started, and that roll-in phase or the startup phase usually takes longer than expected, but sometimes we're surprised. So where we are now is what we had anticipated to find. We are in a good spot in various regions, but we still have room to grow for within our study, and we are still looking to recruit new practitioners. We have at least 63% of our practitioners have at least recruited one patient. And I'm going to point out a couple of things. So if we look at the recruitment of the practitioners right now, we're somewhat unbalanced in the country. That may or may not have a significant effect on our outcomes, but we would like for this card to be, for this map to be evenly colored. So we're represented throughout the country. So right now, of the South Central regions, are overrepresented. So you have really other areas that are underrepresented. If we look at who the practitioners are, and this is you, on average, we have about 40 to 60% female to male ratio. We have mostly general practitioners, and we have a few prosthodontists in our cohort as well. So the practitioners recruit the patients who then contribute implants, and we've made the implant the unit that we are following, in part because it was easier to budget, but it's also of great interest to us to look at these events per implant. So what we have found is that the patients that are enrolled in this study population are generally patients that have one or a few implants. We don't have a lot of patients with a lot of implants. And that means that we have about 1.3 implant per patient on average contributed. That means that we need quite a few patients in this study, and we still have room for additional patients. We also have found that we have practitioners that are very active within the study, and that about 10% of our practitioners currently enroll about half of the implants. That's not uncommon in studies like this, but we really are looking for all practitioners to contribute as much as they can within their practices, and we like our high contributors. So if we look further at our implant enrollment, we are right now still enrolling. We have enrolled 1,298 implants of our goal of 2,000. And we can see that there's different regions that started at different paces, and they're currently still enrolling. An important event started to occur around the start of fall, and that we now have patients that have been enrolled that are reaching the 1 year point. This is a very important point for us because we want to enroll all these implants, gather all this baseline data so we can come back and analyze what the baseline characteristics were that were associated with success. But we can't do that without follow-up. So currently we are in the follow-up phase, and we're right on target with these numbers. So our enrollment was more slated to occur about this time of the year and really taking off. So we anticipate that our year one completion rate will be high because we have very dedicated practitioners, but we also anticipate more of this data coming in. So as that data comes in, we are now able to correlate what happened at year one and eventually at year 2 and year 3 as well. So if we look at where we were at baseline again of our patient characteristics, they are kind of what we had expected, and they follow the makeup of our American society. Although in studies we tend to have a small bias towards female participation, and we see that. We have about 56% female and 44% male. If we look at the community type, 63% identify as suburban, 14% are rural, and 23% are urban. And then if we look at our insurance characteristics, we have 64% have private insurance. There are a couple of public insurances that do pay for implant therapy, and we have combined as well. And we also have a cohort of 20% that is a fee for service. If we look at the mean age, we are slightly on the older side for a study, but that's anticipated for this type of clinical work. So our mean age is about 59 years old, and we are about 79% white population. Of our health characteristics, we have about 9.7% that have diabetes, and that's right in line with the national average. We have about 4.9% of osteoporosis, And it's odd to be happy about smoking, but we have a considerable cohort that is a smoker. And that will allow us to make some great statements about care for patients that smoke. Because odd enough, we feel smoking is a strong predictor of complications, particularly biologic complications. We don't have large cohort studies like this that further evaluate that role. So having a considerable number of smokers makes us be able to complete those analyses. If we look at the prostheses that are in our study, and this is also important for us, based on the baseline enrollment, we can start to look at some hypothesis testing. So most of our patients that are enrolled in the study contribute one implant, about 76%. And then earlier, I already told you that we have a smaller segment that contributes two, and an even smaller segment that contributes three or more implants. If you look at that type of patient, those types of patients are generally restored with fixed prosthesis, and that's also represented in our data. So the great majority of our prostheses that we have enrolled are fixed prostheses. And then if we look at that, they're mostly single unit prosthesis. So that will be a large focus of our data analysis. This data to me is interesting because if you look at the teeth that were replaced with dental implants that are enrolled in our study, there seems to be a bias towards the teeth on the left side of the arch. And I'm not sure if that is because the majority of our practitioners are right-handed, but it's an interesting set of data. And I'm not sure what we're going to do with the left versus right, but we do see that we have a distribution of implants throughout the mouth. Both the anterior region as well as the posterior regions are represented within our study. And I'm excited about the distribution as I see here. So in addition to looking at their overall health status, we're collecting data on their oral health status, and we look at their periodontal disease status. And we see that in our study at baseline, the majority of our patients are healthy or have gingivitis. And there's actually only a small cohort that was diagnosed with periodontitis. So this is only 15% of our study population that's diagnosed with periodontitis, and that's lower than what we see on a general population. But considering the concern about the risk that periodontitis may represent, that may have been one of the reasons patients were selected to receive implant therapy. So our radiographic data is very important, and we continually monitor that data as it comes in. We constantly review those radiographs for quality and ask for potential replacement radiographs, but that's not a common occurrence. Most of the radiographs we receive are of good quality. And the way we look at that quality is can we judge the crestal bone? Can we see the full diameter and preferably the full length? But we need either the length or the diameter of that implant so we can convert our measurements to millimeters, and we use the actual dimensions of those implants. And we also want to make sure we capture that crestal relationship, and we tend to do so when we have quality radiographs like this, where we capture nice, crisp threads. So of our patients that are enrolled and implants that are enrolled, we have 82% also with a radiograph that we have present in our current repository. We do, however, have some of our subjects where we don't have radiographs. And that's an opportunity for us to talk about, because we really want those radiographs. Not only do we want them at baseline, we also want them at the 1, 2, and 3 year follow-up. This was one of the inclusion criteria, and we feel that that is the appropriate way to follow an implant, particularly during those first 3 years. So these radiographs are what we consider the standard of the care that is provided within our registry. We have started our image analysis, and we'll be able to do a lot with these radiographs. We're going to look at the linear bone loss. We're going to look at the prosthetic fit of the prosthesis, but we're also going to look at the angle of the abutments, and we're going to measure all that and then correlate it back to our baseline characteristics and our potential complications that may occur. So in summary, we're still recruiting. We are well on the way to meet our recruitment target of 2,000 implants. What I have presented to you today are merely some interim analysis in which we used raw numbers and proportions and averages. We are going to do far more sophisticated analyses. And one of those that I could anticipate is looking at the difference in biologic complications between a cemented versus a screw retained prosthesis. We're going to look at different restorative materials. We're going to look at the opportunity to look at smoking and other systemic factors on the outcomes, particularly on the biologic outcomes. So currently we have about 65% of our implants enrolled. Of our target enrolled, we need 702 more implants. So I encourage all of you to be on the lookout for your next patients that could be part of our study. I understand that this represents a burden for your practice, but I really appreciate your interest in advancing the generalizable knowledge about implants and how we all together can impact future implant care. Thank you very, very much for the opportunity. I will now allow Dr. Shuler to share his experiences with the study.
Hello. I started recruiting my first patients in October of 2022. And right now I've just started doing my 1-year follow-ups. I've got 4 of those done. I've recruited as many implants as I can, so I've maxed out my number. I've found my patients to be very receptive to being included in a study when I tell them it's a university-based study and that they're going to be doing good for basically for mankind, get us some information. I really think I've only had maybe one person that say they didn't want to be involved in the study when I approached them. So it has not been hard to recruit people, and people are interested in it. And as I said, I'm doing the 1-year follow-ups now, and the people have been interested to come back and get the follow-ups, and it's not a problem to recruit. And it hasn't really been a problem to upset the flow in the practice at all. We're able to do it pretty easily, and I gather my information and input my data later, so I don't feel like I have to do it right when the patient's in the chair. So that allows me to do it later in the day when I have a break in my schedule. So overall, I've found it to be very positive for the practice and positive for my patients.
Thank you, Dr. Shuler, for sharing your experience with us. And thank you, Nico, for presenting on the study updates. We would love to answer your questions about this study. And you can use the Q&A button in the bottom of your Zoom screen. And Dr. Shuler, I would like to start and ask you, how is the process of recruiting the patient? Do you have a dental staff that helps you? And when do they answer the questionnaires? 2 questions.
They answer the questionnaires. Well, the first one, I think the patient gets a questionnaire in the email, so they don't even answer that in the office. So either my assistant or myself will give them the informed consent and go over that and explain the study. So it takes very little time really in the office, and then I just collect my data, and then I'll make my quick notes, and then I'll go back into the computer later and enter all that information. So I do most of it myself, although my staff does the paperwork.
And this is something that we've seen with our practitioners. So one of the things we do is we do look at feedback we get from the practitioners. Early on, we realized our survey was not structured in a way where it was very easy to look at what needs to be collected chairside and what could be collected later on. So we did a little bit of a mix up of those questions, and we focused on what really is needed chairside versus later on. So I appreciate your overview of how you have managed the data collection.
Is there any feedback from patients? I love that you say that it's for the good of society and explaining that to the patients, because that's, I feel, is the it's the fundamental thing that we do, is generate generalizable knowledge, and that's why we are doing research, right? Usually our patients don't reap the benefits of the research, the ones that are participating in the study, but having that perspective that we are doing that for the goods of society, it seems that your patients accept that really well, Dr. Shuler. Is that what
they seem to? I had one patient withdraw. He's an older gentleman, and I think he just didn't want to deal with the app on his phone or the internet or whatever. So he did withdraw, but he is also the guy that every time he comes in the office and I ask him how he's doing, his standard response is horrible. So, you know, he did withdraw from the study, but everyone else has been very positive about the study, and I haven't gotten any negative comments from anyone.
That's great to hear. What are the ways to engage patients to ensure that we get the follow-up?
For me, with the follow-up, we've got one of my assistants did the whole spreadsheet before I even got the information from you as to the timing. And then we just have made phone calls and brought people in. And of course, I tell them they're coming in, there'll be no charge for what we're doing. We take an x-ray and do the exam, and I don't charge them, even if I can incorporate it into a regular recall exam, I do, but I had some people come in that aren't necessarily the best at following up on their own recall, but they've still come in for the follow-up on the implant when we called them and asked them to come in. So that's going fairly well.
Nice to hear. We have a question. How much time does it take you to complete the surveys, the forms for this study for one implant?
The surveys that I do on the computer afterwards?
Yep.
Maybe 5 minutes. Maybe. It doesn't take very long. I mean, probably the first one, getting used to them took a little bit more time, but once you know what's being asked for and you go through it, it doesn't take very long. But maybe 5 minutes. Not much.
And that's important information, because it does take some getting used to the questions, but once you've answered them once, not only will you be able to fill out the survey easier, but it also prompts you to think about what data we're collecting. So you have that available to you by the time you fill out those surveys. And I appreciate you indicating that was something that improved quickly after you started the study.
Dr. Geurs, did I hear correctly that there aren't many cohort studies on smokers and the implants success?
So we do have studies on smoking, but they tend to focus on smaller groups, and they tend to not have, they tend to focus a lot on early wound healing. So it's the early phase of implant dentistry. They tend to not have long-term follow-up. One of our hypotheses we will test is when do the complications occur in smokers? One of the thoughts is that this actually needs a little bit of time. So we may not see that early on, but we see them kind of later in the implant's life. So we want to make sure we capture data like that are longitudinal and less focused on just the early wound healing around an implant or the early performance, and in a prospective manner as well. So we do have some retrospective studies, but they tend to not have the data we'll have prospectively on these cases. Because I could also anticipate that we'll find that a certain type of prosthesis may perform better in smokers than other prostheses. So that's data that we'll be able to provide answers to, and we don't have studies that are that comprehensive. Even though smoking shouldn't be something to be excited about, I'm excited we have a very representative sample of our population from that perspective.
Means that we will also have some patients with periodontitis, which also may have differential success rate for implants.
Yeah, so that's another area, but that's where I was kind of looking at the data. And so we don't really direct that data, but if we look at the general population of 58, we would have expected a greater number of patients with periodontitis. But we also think that sometimes if we select candidates for implants, we may be more cautious in placing those with severe periodontitis. So from that perspective, I can understand that we don't have those represented in our cohort.
Dr. Shuler, if there is someone here in our audience that is trying to decide to be in this study or not, what should you tell them to support them doing the DIR study?
Well, I feel I get some satisfaction from knowing that I'm gathering data for a study. My older brother is a dental educator and a researcher, so he's much more involved in that aspect than I am. But I get some satisfaction from knowing that not just treating my individual patients, but it's kind of going to a greater good, or however you want to phrase that. So to know that there is, even though I live in a small, rural town of 2,000 people, I can gather information that's going to be beneficial in the long run. So, I get some personal satisfaction from it.
And that really is the power of the network. We give that opportunity to anyone in the country to participate, and the data is really gathered in all regions of the country. So an opportunity to contribute to a study like this, you don't have to be at a university center.
Which is also more representative for the care that people receive if you are in a practice than in an academic center. So we do appreciate the participation of general dentists in the communities. So thank you, Dr. Shuler. Nico, we have a question here. What's more important to get, I think, in terms of the radiograph, the abscess or the crestal bone? Should we get a distorted X-ray that shows the whole implant, or one with less distortion but not showing the whole implant body?
Yeah, so we're really looking for a radiograph that captures that relationship of the most coronal aspect of the bone contact to the implant, or the crestal bone. And we do that best if that implant's taken with the capturing screen, film, the phosphor plate or sensor parallel to the long axis of that implant, and the X-ray beam perpendicular to that. So that's easier done in an X-ray that only captures that crestal area well. And if you capture the crestal area well, you'll have the diameter of the implant captured. And that allows us to say, hey, this implant diameter is 4 millimeters. I can now measure that implant diameter, take the amount of pixels that are in those 4 millimeters and translate to the amount of pixels what my defect is like, and convert that back to millimeters. So capturing a well taken radiograph with the crestal bone is more important than having the full length of the implant on there. A vertical bite wing radiograph is particularly good for that type of radiograph. If you shift that a little further apical towards the length of the implant, quite often can you also capture the full length of the implant. But my preference would be capture that bone relationship and the crestal bone as accurate as you can, and don't have to go for the apex of all those implants.
How important to the study is it to take the radiographs both at baseline and follow-up visits? What are you going to do with this information later on?
Yeah, so this is very important for us because we want to capture bone maintenance around these implants, and we want to capture those changes, and we want to capture when those changes occur. So we've picked our time points to be 1, 2, and 3 years out, and we contrast those out to baseline. So without the follow-up, the baseline radiograph tends to be important only if we have the follow-up radiographs. So we really need that follow-up to be able to talk a lot about biologic complications or changes in the bone levels around an implant. Or to flip that around, because having no complications is a great thing too. We want to make sure we capture when bone is not lost. That's actually our strategies. What are the characteristics of the implant restorations that are most protective of bone around an implant? So we do need those follow-up radiographs.
That in addition to a clinical exam, right? There is also a form about the oral health status of the patients.
Yeah, so correct. Our follow-up survey is not nearly as complex as the baseline survey, because in the baseline survey, we capture everything that we've done therapy-wise. That tends to not change. Now, if changes occur in that therapy, we ask you to capture that at that 1 year point. But we also want to capture the status of the prosthesis, as well as the status of the tissue surrounding the implant at that visit. And again, we contrast that back out to baseline. So we need to make sure we have baseline data as well as follow-up data.
Mm-hmm. We have another question here. Dr. Adams is asking if photos of the gum line would be supportive to this study.
We have not set up a tool to capture those. So I could see they would be of interest, but we don't have a good way to capture that for all of our subjects, and we haven't asked for that data. So instead of the photographs, we are asking for clinical measurements of that gingival margin in relation to the crown, as well as the probing depths around the implant. So we have not asked for actual photographs. If I were to look at things in the future, I could see we would actually ask digital scans, but that way maybe way out for a next study. But there are lots of cool ways that we can now capture things digitally, and that makes it easier to share. Digital radiography makes it possible for us to collect these images quite easily and enhance our data, because now we can actually look at the raw data, take our measurements, and standardize how we take that measurement. So the radiographs are important. Photographs we're not asking.
So maybe in the future, when we do the DIRR 2.0, we may add some pictures. It will be really nice to illustrate also what we are talking about when you talk about the measurements.
And at some point, we may come back to individual practitioners if they're willing to share those, so we can get some good examples. The radiographs are kind of our opportunity to have that. And the reason we didn't ask for photographs, this is another level of infrastructure a practitioner has to have available to them. And we know every practitioner takes radiographs. We didn't know for sure if every practitioner would take photographs.
So any last thoughts or comments or suggestion for this study? Dr. Shuler, would you like to share your final thoughts about it?
When you talked about smoking earlier, I've actually had probably at least 2 or 3 of the patients I did implants on quit smoking because I told them it was detrimental to the implant. So I don't know if that skews the data because you don't have the smokers anymore, but it's actually been beneficial to a couple of patients that have given up smoking because of being involved with an implant. That, I mean, from my point of view, that's a very positive thing.
That allows me to plug one of the other studies we do within the network, because we as oral healthcare providers do play a very important role in our overall health of our patients and in behavior modification. And what Dr. Shuler just described is a perfect opportunity we have. The patients dealing with a new situation, that often gives them an opportunity to learn. And in that environment, the right type of education can really have a great impact. And I don't think that that's something that will skew our data. I think it's something we will capture. So now we have a past smoker in our study, and that's also important. So no, I think that's a great opportunity. So if you're interested in the study I just described, the network webpage has information about that study, and their PI is called Dr. Japuntic, and the study is called the FRESH study.
Thank you for putting the plug on that, Nico. We appreciate that. What about what can you share with our audience today about this study? What is your expectation for the future and the follow-up visits?
So I'm really excited about the data we're gathering. It's a lot of data. It takes a long time to get to a lot of data, but we're able to answer questions from a different perspective. I was used to doing university-based smaller studies in which we can show a trend, but how this all translate into practice is captured in our study. So it will be the largest cohort study on dental implants in the United States that is prospectively designed to answer very important questions about biologic and prosthetic complications. So we need all your help. We really have an incredible framework around this study that supports the study, but it all happens in your practices. So we appreciate all of you having contributed to our study, and we hope to share with you the first real follow-up data once we have our year one cohorts completed, and we're going to share the baseline characteristics once we have completed our enrollment of the year one, or the baseline data.
Thank you, Nico. It's very exciting to see the baseline data for this study and seeing some initial preliminary results. I really appreciate you presenting that to our members. And Dr. Shuler, thank you so much for being here today, presenting about your experience doing this study. And we are looking forward to our next opportunity to be together here for a webinar. Thank you very much, everyone, and I will see you in our next webinar.
Thank you, Joanna.
Yeah.
Bye, everyone.